Blood gases are a great test. They're easy to take, they only need a small amount of blood, and we can get lots of great information from them. This video is based on Dennis Wren's brilliant DFTB post, and I'll post a link in the description below the video. Here are 3 simple steps to take you through basic blood gas interpretation. Now, before we kick off, remember that blood gases can be taken from arteries, from veins, or capillary samples. All of these are valid, but you need to know the context of them to interpret the nuance. Now, there's loads of nuance around blood gas interpretation, and in this video, we're just going to go through the very basics, which is why we've split it up into 3 simple steps. So let's do it. You need to understand the components of what you're looking at in a blood gas. The first thing you're going to see is pH. The normal pH is going to be between 7.35 and 7.45, and this is what you're going to use when you're thinking about whether the patient is acidotic or alkalotic. Next, you'll see PCO2. This is the partial pressure of dissolved carbon dioxide in the blood. The normal range is 35 to 45 millimeters of mercury. Make sure the units is right, because in some countries they'll use kilopascals instead. That is a different number and a different range. It'll be 4.5 to 6 kilopascals. PCO2 is where you're going to look to see if there's a respiratory component to the blood gas result. Then we've got PO2. This is the partial pressure of dissolved oxygen. What the level is here is going to depend on what type of gas you've taken, i.e. whether you've taken arterial, capillary or venous. In a VBG or a cap gas, it's probably not that useful. Then we've got HCO3, which is bicarb. This is really useful. Your normal range is going to be between 22 and 26. And you're going to look at this to establish whether there's a metabolic component to the blood gas. And the last really important piece of information here is the base excess and the base deficit. This should be ideally somewhere between -2 and +2. This is going to tell you the amount of acid or alkali needed to get the pH back to normal. So if it's negative, there's a deficit. If it's positive, there's an excess. Now, you might see lots of extra information on your blood gas, depending on the machine. You might have sodium, glucose, lactate, hemoglobin, calcium, potassium. All of these things can be really useful once you get to the nuance of understanding blood gases, but today we're going to stick to the very basics, so we're not going to go through these. And the reason for this is that to understand the basics, basically everything comes back to the concept of understanding the pH of whether it's acid or alkali and why that has happened. Because the body wants to maintain a normal pH, and it has 2 ways of doing this. It can do this through the lungs, or it can do this through the kidneys, and that's why we look at the respiratory or the metabolic component. Because the lungs help regulate the CO2 and the kidneys help regulate the bicarb. And now we get to your 3 steps to interpreting a blood gas at the basic level. Step 1. Is it acidosis or alkalosis? To do this, you look at the pH. If the pH is less than 7.35, the patient is acidotic. If the pH is more than 7.45, the patient is alkalotic. This is really easy. Quick glance, is the patient acidotic or alkalotic? Just remember here, it is possible to have a normal pH, but to have 2 disturbances that balance out. So you could have a very high CO2 and a very low bicarb and still have a normal pH, but there is a problem. But this gives you a first glance look by looking at the pH. Step 2 is the acidosis or the alkalosis. You found respiratory, metabolic, or both. So you're going to look at the PCO2. If you've got a hyperventilating patient, they'll be blowing off CO2, and their CO2 is going to be less than 35 millimeters of mercury. If they're doing this and they've got low CO2 and a high pH, this is a respiratory alkalosis. On the other hand, if you've got a patient who's not ventilating well at all and not breathing, their PCO2 is going to start to rise, so they may have a PCO2 that's over 60 millimeters of mercury. This is going to be a respiratory acidosis. Next, you're going to look at the bicarb. If the patient has a normal PCO2 but a high bicarb, then that patient has a metabolic alkalosis. If the patient has a normal PCO2 and a low bicarb, then that patient has a metabolic acidosis. If your patient has a metabolic acidosis, this is where you calculate the anion gap, and you can see the formula here. And make sure you have your favorite mnemonic to hand to remember all the possible causes of anion gaps. And step 3, is there compensation? So we've looked at whether we've got acidosis and whether it's respiratory or metabolic, but then you look, is there compensation of the other element? If the patient's got metabolic acidosis, then what you want to then look at and see if there's respiratory compensation. So respiratory compensation would mean a low PCO2, so the patient might be hyperventilating to try and blow off CO2 to help balance that pH. So if that was the case, this would be a compensated metabolic acidosis. But then if you've got a respiratory acidosis, you want to look to see if there's metabolic compensation. So in a respiratory acidosis, you've got an acidotic patient with a high PCO2, and what you want to then look at is the body compensating for that acidosis? And they would be compensating by holding on to more bicarb, so you would expect to have a higher bicarb if they're compensating. That would be a compensated respiratory acidosis. And here's a nice little table that will help you work out whether your patient has a respiratory primary problem or a metabolic primary problem and whether there's compensation or not. it helps give you an overview of how to look at the gas. So we're going to be a few scenarios to help just run through some cases and check that we can work through that 3-step plan. Joanne is a 6-year-old girl. She's presenting with lethargy, vomiting and abdominal pain. Her parents are worried that she has been drinking a lot in the last few weeks, but she's been peeing a lot and she's been losing weight. You can see when you examine her that she looks tired, she looks pale, and she seems to be breathing pretty quickly. She's also tachycardic, but her lungs sound clear when you listen. Okay, so let's look at Joanne's blood gas. Step 1 is the patient acidotic. So the pH is 7.12 here, so this patient is definitely acidotic. Step 2 is the acidosis caused by a metabolic problem or a respiratory problem or both. So we're going to look. The respiratory component, we look at the PCO2 and it's 20. That is not high, so a high PCO2 would cause an acidosis. So it's not a respiratory acidosis. Then we look at the metabolic component. So the bicarb is 9. 9 is a really low bicarb and it is a metabolic acidosis. So that's step 2. Then we go to step 3. Is there compensation? So if you've got a metabolic acidosis, you then want to know, is there respiratory compensation? Respiratory compensation here is going to be a low PCO2, and that's going to be because the patient's probably hyperventilating to try and blow off PCO2 to help settle their pH. And if you look, we can see that actually the PCO2 is low, is 20. We've said the normal range is 35 to 45 millimeters of mercury. So this is a metabolic acidosis with respiratory compensation. Actually, you can look at the other value on this blood gas, and it might not surprise you from the very clear history that Joanne has a really high glucose, and that's because what we're seeing here is a diabetic ketoacidosis. It's a really common presentation of metabolic acidosis with respiratory compensation. Case 2, we've got Peter. Peter is 5 years old. He presents with an acute exacerbation of his asthma in the context of a viral illness that he's had for the last few days. When you listen to him, he's really wheezy, he's working hard, and you start going through your asthma management protocol. Actually, when you come back to see him an hour later, his breathing has slowed. He seems much more sleepy and you can no longer hear a wheeze or really much air at all when you have a listen to him. It's time to do a venous blood gas. So question 1, is this patient acidotic? The pH is 7.36. This is normal, so the patient is not acidotic. Then you're going to look at the other elements about respiratory or metabolic components. So the PCO2 is normal, just to the upper range of normal, and the bicarb is 24, which is bang in the range of normal too. Here is a good example because we do not want to be falsely reassured by what appears to be a normal blood gas, because this patient is very worrying. In a patient with asthma, they're breathing very fast. You'd actually expect their PCO2 to be low because they're blowing off CO2. This patient's PCO2 is rising. It's still within normal, but it's going to the top of the normal range, and that's because Peter is getting tired, his breathing is slowing, his PCO2 is going to rise, and this should be a big warning sign to you. Peter is no longer moving air in his lungs, and rather than hearing wheezing, you are hearing nothing. So this is a great example when in asthma, you might see this, which may appear to be a normal gas, but it's actually pretty worrying. And the third case I'm going to share is Diego. He is 2 years old. He's got fever, lethargy. He's had a cough and a runny nose for the last few days. He's tachycardic and his cap refill is not good. And you get blood gas from him. Question 1, is he acidotic? Well, his pH is 7.25, so he is indeed acidotic. Then, step 2, is it a metabolic acidosis or respiratory acidosis? You can see that his PCO2 is low rather than high, and so it's not a respiratory acidosis. Where we look at his bicarb, though, his bicarb's 14, so it is definitely a metabolic acidosis here. Step 3 is there respiratory compensation? When you've got a metabolic acidosis, you'd expect for the PCO2 to be low to try and compensate, so the patient would be hyperventilating to try and blow off CO2. We see that the PCO2 is maybe a little bit below the normal range, so there may be some element of respiratory compensation here. However, what you do note on the blood gas is that you can see that the lactate is 3.6. This suggests poor perfusion. What you're seeing here is likely sepsis, and specifically septic shock. Diego is lethargic, he's tachycardic, he's poorly perfused, he's got high lactate, and he's got a metabolic acidosis. Remember that sepsis is not just diagnosed on a blood gas, but this is the kind of picture that you might see. Have a high suspicion for sepsis and treat it early with fluids and antibiotics. These are your top tips for simple blood gas interpretation. If you enjoyed this video, you'll enjoy my video on 5 things that you need to know about bronchiolitis, which you can see right here.